I welcome you to New York. Those of us joining via webcast to the program, Point, Counterpoint, Experts Debate Key Questions in HIV Management. And I hope you'll agree these questions are quite timely. This CME program is jointly provided by the Annenberg Center for Health Sciences and Clinical Care Options and is supported by an educational grant from Janssen Therapeutics. I'm Eric Daar. I'm the Chief of the Division of HIV Medicine at Harbor UCLA. And Professor of Medicine at the Geffen School of Medicine at UCLA, and I'm thrilled to be joined by my colleagues, Kate Squires and David Wohl, for this particular session. So I'll be providing a brief overview, and then we will do this point-counterpoint, where we're going to debate three key issues. Are the DHHS guidelines wrong to admit NNRTIs from recommended first-line options? I hope all of you have had an opportunity to see the new DHHS guidelines. There are some very key changes from previous guidelines. Are single tablet regimens the best choice for nearly all patients? And are boosted PIs still appropriate for first-line therapy for many patients? Okay, great. So this brings us to the debate on these three key questions. The rules of the game are that for each statement, one of the faculty will present the case favoring the proposition statement, and the other will highlight the case against. The positions were assigned, so they don't necessarily reflect our actual views. And the participants will vote for the winning position after each topic. We'll actually ask you for your opinion before as well as after to see if you're swayed by one of the faculty more than the other. And then again, fill out your question cards. The other thing that I'll mention is at the end, we will then just state what our actual views are after the debate. So the first question is, the DHHS guidelines were wrong to omit NNRTIs. For those who haven't seen them, these have now been moved from a recommended to an alternative option, all NNRTIs. I will make the debate for the guidelines being wrong to have done so, and then Kate will argue against. So let's go ahead and start by voting and ask the audience. Most of you are sitting, which is great. The DHHS guidelines were wrong to admit NNRTIs as recommended first-line options. Do you agree, disagree, or you're undecided? Go ahead and vote. Okay, about 60% agree. Very good. So I'm going to just cover some of these issues about why I think NNRTI-based regimens are valuable and agree with the majority of the people in the room. They're obviously convenient. Both of them are available as single-tablet regimens, meaning rilpivirine and efavirenz. Efavirenz has been the longest duration of use of any preferred agent with excellent virologic efficacy, in fact, never beaten in any clinical trial for pure efficacy. It's a first-line regimen that's been adopted by the World Health Organization and, frankly, is a recommended option in every major guidelines in the world, except now the DHHS guidelines. Efavirenz and rilpivirine are tolerated well by most patients. Much data is available on how to manage people with first-line NNRTI failure. And for many payers, they're two of the lowest cost options for therapy. So these are just some of the guidelines. These are the WHO guidelines, which now prefer efavirenz, and the IAS USA guidelines, which have efavirenz listed as a preferred option. And we could list the key European guidelines, and they too list efavirenz as one of the preferred options. This describes some of the key studies using efavirenz-based regimens for first-line therapy. If you do the math, it adds up to over 5,000 patients in these clinical trials. Overall, very, very efficacious, as I said, never beaten for pure efficacy, generally well tolerated, particularly in some of the more recent studies with more contemporary third drugs that they're combined with, nucleosides that they're combined with. Rilpivirine is also effective, highly effective, and very well tolerated. This is the head-to-head comparison in ECHO-THRIVE with rilpivirine versus efavirenz, where you may recall that, especially in the people with the viral loads of less than 100,000, it was as efficacious, and in the STAR study, it even appeared to be more efficacious than efavirenz, with far fewer of the common side effects that are associated with efavirenz and sometimes limit its use. And then as far as managing NNRTI failures, there's no setting that we have more data. This is data from the second-line study. There's another study called EARNEST, and there's another study that will probably be coming out soon from the ACTG, all of which demonstrate that you can effectively manage these people with lopinavir, ritonavir with recycled nucleosides or lopinavir ritonavir with an integrase inhibitor. And the guidelines clearly state there are various strategies that can be used in managing these people. And now Kate is going to tell us why, despite the fact that every guidelines panel in the world, including DHHS for probably better than the last decade, why all of those recommendations are wrong.
Okay, David. So let me first of all point out that he had 6 bullet points. And how many do I have on my slide? 8. All right, so superior position to begin with. All right, so there's just a few things that we need to keep in mind about NNRTI regimens, and these are many of the reasons that really led to the DHHS guidelines panel, at least, to demote these drugs. So there is clearly the highest level of transmitted resistance, and we'll talk a little bit more about that. And for people who fail NNRTI regimens, usually they fail with 2-class resistance, or at least we see that at a higher rate than with the use of other class regimens. Efavirenz has actually been taken off of its podium, if you will, and it's been shown to be less effective than dolutegravir. Efavirenz is still contraindicated in early pregnancy and in women of childbearing potential by the DHHS guidelines. And in this country, about 27% of women, or 20% of patients, HIV-infected patients are women, and most of them in their childbearing years. And globally, over 50% of all patients are women, so obviously that's something that you need to take into consideration in terms of thinking about pregnancy or fertility options when you're talking about regimens with women. Efavirenz has been associated with increased CNS adverse events. I don't have to tell any of you who have used this drug. And most recently has been shown to be associated with suicidality. Rilpivirine, even as Eric pointed out, is ineffective at high viral loads and low CD4 cell counts. And then there's some issues about how to take these drugs. For efavirenz, it should be taken at bedtime and without food. So clearly for people who work in shifts and other types of life events that they have to think about when to take this and maybe can't fit it into their schedules. And rilpivirine must be taken with food, and we're not talking a cracker here, right? This has to be a high kilocalorie load to make sure that there's adequate absorption. So, thank you. All right, so there are many studies that have addressed the issue of transmitted resistance. This is one of the most recent ones, looking at drug resistance in MSMs across some jurisdictions. And as you can see here, as circled, for transmitted resistance, the highest, or the class that has the highest rate of transmitted resistance are NNRTI. So if you're going to use them in treatment-naive patients, you clearly have to have the results of genotypic assays before you start these agents. And next, thank you. All right, and in terms of virologic failure and 2-class failure, this is an analysis of ACTG 5142, which compared an NNRTI-based regimen, in this case efavirenz, to a boosted PI regimen, in this case boosted lopinavir. And the bottom line is on the last column, or the last row here, which showed that for patients who experienced virologic failure, that the percent that exhibited 2-class resistance was 26% in patients randomized to an efavirenz-containing regimen versus 1% in patients who were randomized to the boosted PI regimen. Next slide. This is just to point out that in the DHHS pregnancy guidelines now, you can see that efavirenz is in the preferred category, but as denoted by the star, it can really be used only after 8 weeks of pregnancy. So again, for women who are thinking about becoming pregnant, you have to have this discussion, and you need to think about other drugs than efavirenz-containing regimens if she expresses a desire to become pregnant. All right, in terms of suicidality, this is the analysis that was published about a year ago now in the Annals of Internal Medicine, and the ACTG analysis looking across the ACTG studies that contained efavirenz-containing regimens. And for patients who were randomized to efavirenz-containing regimen in comparison to those who were not, you see that there was an increased number of events. And so this kind of risk of, or at least an association with an increased risk for suicidality. Thank you. And this is, Eric has already shown you an analysis from the ECHO and THRIVE, which was the registrational trial which compared efavirenz to rilpivirine. This is the analysis that broke people out by their baseline viral load and CD4 cell counts. And if you look at the top for viral loads and at the bottom for CD4 cell counts, as viral loads rise and as CD4 cell counts are lower, you see that rilpivirine did not perform nearly as well as efavirenz, which led to the recommendation that rilpivirine can only be used in patients with viral loads of less than 100,000 and CD4 cell counts of greater than 200. And I believe that's my last slide.
Okay. Wow, that was pretty compelling.
Well, thank you, Eric.
Kind of left with what was new in that dramatically changed the world about a month ago. So let's go ahead and vote. As the moderator, I get the last word. The DHS guidelines were wrong to admit NNRTIs as recommended first-line options. How many agree, disagree, or undecided? Okay, well.
Okay.
Kate got some people to change their mind. Yeah, very
Thank you.
good,
Thank
very
you.
good.
I appreciate it.
So she's very competitive. So, I'll go first, and I'll preface by saying that I was assigned this side, and I actually don't think the guidelines were wrong to make the switch. I think it's important to realize, though, it wasn't because there was any new data suggesting a problem with efavirenz. It's really the emergence of new options. And when looking at the long list of really effective options now, we have now several single-tablet regimens that simply are better tolerated than efavirenz. So I find myself really never using that regimen for first-line therapy. That said, the big problem with it is the early side effect profile, for the most part. And if I have patients on it and who are doing well, I would never switch them unless they're having some side effects. Because obviously the drug is good. We've used it for a long time, and the guidelines are specifically speaking to people starting therapy for the first time.
So I don't disagree. I mean, I think that tolerability, ease of use is really the major thing, given that potency is the same across the regimen. So in that respect, I rarely use NNRTIs as a first-line regimen. But like Eric, I have many patients who are still on a efavirenz-containing regimen, and if they're doing well, I don't switch them. And it's nice that we have options.
David?
I completely agree. I think that efavirenz has its issues that you pointed out, where rilpivirine has clearly the limitations that are well acknowledged. And unfortunately, antiretroviral really hasn't been studied as rigorously as we'd like in this space, and I think it would do really well. So I consider that kind of a shame, because I then think we might be having a little different conversation. But overall, I think given the data we have right now, I think it's right to do what the efavirenz did.
Yeah. I must say that I still use rilpivirine in low viral load patients who have no problem with the meal restrictions or acid-reducing agents. But I understand having it as preferred really means that you can use it across a broad population of patients. And the guidelines always say that often an alternative option may be a preferred option for a given individual. So the outcome question, this was the first one, a 25-year-old female, previously untreated HIV infection, visit your office to start treatment. Her viral load is 75,000, her CD4s are 350, HLA B5701 positive, past history of depression in her teenage years, but is currently asymptomatic, expresses no adherence concerns, and wants to consider all options. Doesn't matter if it's recommended or not, all options, because she's job searching and unsure of her insurance coverage. So go ahead and vote again on this question. When recommending therapy for the patient, which of the following would you more likely avoid? The efavirenz-containing elvitegravir-Cobi, darunavir, ritonavir, raltegravir, rilpivirine, or you're not sure. Go ahead and vote. So the overwhelming majority said they wouldn't use efavirenz. And I think that that's reasonable. All of these are probably fine options for her, but I think based on her history, given a choice of which we might not pick, this would probably be the one. Any thoughts? Okay. Okay, the next issue is whether single tablet regimens, for which we currently have 4 and probably more coming, whether they're the best choice for nearly all patients. And Kate's going to argue for this, and David will argue against it. But first, let's ask all of you. Do you think a single tablet regimen is the best choice for nearly all patients? You agree, disagree, or you're undecided? Go ahead and vote. Okay. So,
Interesting.
I don't think they should show us.
oh, okay.
Don't show us.
Okay. Okay,
Oh, don't worry.
You're on.
you're on.
Okay.
Kate's feeling pretty confident after the
Yeah,
first
right.
one.
All right, so let's get started. Simplicity, I don't think I have to say anything more about that. Convenience, not much more to say about that either. The nice thing is that these single tablet regimens do not make you sacrifice anything for efficacy or potency. Certainly in terms of patient preference, there's a lot in the literature. You guys deal with patients all the time. Less is more in this case. Fewer copays, which is certainly very important for our patient population, and reduces selective non-adherence to components of the regimen. So if they get that pill in their mouths, it's all over with. They've got their medication for the day. Also, it has been shown in some studies that patients who are on single tablet regimens have less hospitalizations. And the good thing is that single tablet regimens of other classes are being developed. So in the not too distant future, you would have the luxury of being able to use a single tablet regimen that represents all of the classes that we currently have available to us for the treatment of HIV infection. Next. So back to the guidelines, and it doesn't matter whether it's the DHHS guidelines, the IAS USA guidelines, or the WHO guidelines, single tablet regimens are featured very prominently across all of the guidelines. And in turn, I already mentioned about the potency and efficacy. Now, listed on this slide are the single tablet regimens, showing you what has been demonstrated in many of the pivotal clinical trials involving these regimens, that we see very high rates of virologic suppression, and again, demonstrated in a number of clinical trials. So no question about potency or efficacy. So in terms of this issue of do we really see better adherence, and in this one study, lower risk of hospitalization, this is from Paul Sachs, an analysis done from a large commercial insurance database, demonstrating that patients were broken out by whether they were on 1 pill, 2 pills a day, or 3 or greater pills a day. And in comparison to patients that were taking greater than 3 pills a day, patients on the single tablet regimen were more likely to achieve adherence and less likely to be hospitalized, as is demonstrated in this graph, and showing that the rate of hospitalizations significantly lower in patients who were on 1 pill a day regimens. If you can go on. So in terms of patient satisfaction, here's a study from Edwin de Jesus looking at patients who were on stable antiretroviral regimens who were randomized to simplify their regimen to a single tablet regimen, in this case the efavirenz-containing regimen, or to stay on their same regimen. What they did demonstrate is that the likelihood of maintaining virologic suppression was the same across both arms of the trial, which is not surprising because people who were on successful regimens likely to continue to be successful. And there were high rates of adherence. But when the patients were asked about their satisfaction with the regimen, you can see that for patients who were randomized to the simplification, to the efavirenz-containing regimen, they considered that to be very easy to take compared to a lower percentage of patients who were maintained on their regular regimen. And after the study was over, patients who were randomized to the single tablet regimen really preferred this over what they had received previously. So patients voting here. And then in terms of looking at adherence, this is a study from David Bansberg looking at a very challenged group of patients, and those are patients who are homeless living in shelters in the San Francisco area. So he looked at patients in the REACH cohort and compared them to historical controls. And he was able to show that for patients who were on a single tablet regimen, again, in this case an efavirenz-containing regimen, that they had a higher likelihood of virologic success, defined as viral loads of less than 50 copies per mil, and that the adherence was greater. And again, this is shown in the graph on the right-hand side of this slide. Much statistically higher rates of adherence than patients who were receiving anything more than 1 pill a day. Okay, and there's my presentation.
David, tell her why she's wrong.
Yeah.
Good luck.
At first, I wasn't excited about getting assigned this Counterpoint, but then the more I thought about it, the more I felt sorry for Kate, because here she had to argue that there was something that was going to be really recommended for nearly all patients. And it's really hard to think of something other than you should start HIV therapy in everyone that you'd recommend for nearly all patients. The beauty, I think, of what we do as HIV clinicians is that we individualize and tailor our therapies to the needs of our patients. And one size doesn't fit all. And as I'll point out in the next few data slides, there are limitations to our single tablet regimens. And I'm not saying, of course, that I think people should take 5 pills a day. I think we're well beyond that. But I don't think we have to be as dogmatic as we have been about we need to take a single tablet, and anything other than that is substandard. I think it plants into our patients' heads that, if you don't get a single pill, there's something wrong with you or there's something wrong with me. So let's think about that. One thing is that there's lots of highly effective regimens that are not single tablet regimens, and I'll point that out in a second. For instance, there's not PIs, and sometimes we want to use a PI, and there's not a single tablet regimen right now, and there won't be for the foreseeable future for the next few years that contains a PI. I'll also show you that there's data that indicate that our perception that single tablets are really the best thing since, seedless watermelon is not true. And that when you look at the data, the outcomes don't support all that's gone on with the sort of investment in single tablet, single tablet, single tablet. I'll also point out as well that the limitations of the current single tablet regimens are really going to burden our patients with toxicity, relative toxicity. Most of our therapies are well tolerated, but I'll point out single tablet regimens we have right now still have unacceptable side effects for some of the drugs that are contained within them. And lastly, and this is really an important point that I think really gets to this, again, I think we've drank the Kool-Aid on single tablet regimens that's being fed to us by the pharmaceutical companies. So they get to hold on to their patents, they get to hold on to their profits as long as we don't break up single tablet regimens. As generics come along, we're going to have more options to treat people with very effective regimens that are not going to be as expensive. And you're going to hear a lot of people and a lot of data pushed to you saying, oh no, but single tablet regimens do X, Y, or Z, thus you should use our expensive drug. So let's go through some of the data. Kate talked about guidelines. Let's look at the guidelines. So the majority of the recommended regimens by the DHHS are not single tablet, right? So I think this is really important. I would posit to you that probably the cleanest, most potent, most indemnifiable against resistance in one package is not going to be a single tablet regimen. It's going to be dolutegravir, tenofovir, FTC. So that's 2 pills. That's totally acceptable. That tenofovir, FTC, dolutegravir together, most people can take. I think there's very few people who would be assigned a single tablet regimen that would not do well on 2 pills once a day, given that regimen. So let's go to the next slide. So again, as I mentioned before, there's limitations of every single one of the single tablet regimens. I'm not going to rehash this, but you all know it. There's major limitations here. And if we break out of this mold of a single tablet, we probably will do better for our patients and their long-term success. Next slide. So here are data that have been pointed out a number of times, and I think you'll see this later on in the afternoon, comparing abacavir, 3-TC, and dolutegravir, or FTC, tenofovir, and dolutegravir with each other, right? And so dolutegravir with tenofovir FTC, as I mentioned, is not a single tablet, but abacavir 3-TC dolutegravir is. So you might say, okay, dolutegravir is great. Dolutegravir also leads to indemnification against resistance. Even within this study, you can see that there was at least a suggestion that tenofovir FTC dolutegravir does better than abacavir 3-TC dolutegravir. So even when you're talking about a very potent, user-friendly drug like dolutegravir, I think that we're seeing that there's some evidence that the single tablet formulation of abacavir 3-TC dolutegravir may not work as well as splitting it up into 2 different medications. So this is just one example, I think, and I could show others. Next slide. Again, I mentioned before that there's data. So there's perception, and then there's data. And human behavior is complex, not only our patients, but our own. So we think single tablet makes sense because, the less is best. That's what Kate was talking about. It turns out that the data don't exactly support that, and there was a really nice analysis, a meta-analysis of 9 different studies that looked at fixed dose or single tablet regimens versus multi-tablet regimens. And they had various endpoints that you'd care about. Next slide. And what you'll see, and I'll go over in a second, is that there really isn't much difference when it comes to virologic outcomes when you're talking about 1 pill versus 1 or versus 2 or 3 pills a day. Next slide.
So when you look at virologic failure, there really wasn't a significant difference in outcomes between single tablet and non-single tablet regimens, treatment emergent resistance, not a difference as well. And there was no difference between discontinuation for AEs. And again, as Kay pointed out, there is a preference. People do want to take 1 tablet a day if they can, but for their own good, sometimes 2 tablets is really better for them. And even then, even with the preference difference, adherence wasn't significantly different between the two. So again, I don't think that 1 tablet means that people are not going to, that 1 tablet is going to ensure that everyone's going to take their medicine, and a 2 tablet means that they won't. I don't think that's being shown in these data. Next slide. I'm not going to harp on this. Clearly, the single tablet regimens we have right now contain tenofovir or abacavir. Tenofovir has its bone issues and its spine issues. We know about that. Next slide. It has its renal issues, so that's going to be a handicap for those tenofovir-containing regimens. And I know that we're going to have TAF FTC soon. That just leads more into my point. When we have TAF FTC as a single tablet regimen in about 6 months, you'll see all of us will be breaking up regimens and we'll be giving people TAF FTC plus fill in the blank, dolutegravir or something else, and we'll move on from single tablet. And abacavir as well, we all know its baggage, and I think using abacavir in a single tablet regimen doesn't do many of our patients any favors either. So overall, again, I think we have to break out of this mold and not be dogmatic about single tablet regimens is good for nearly everybody.
Okay, good. So let's go ahead and vote. Single tablet regimens are the best choice for nearly all patients. Agree, disagree, or undecided? Wow. Kate, do you agree that with the audience having been swayed by David's argument, or?
I'm not talking.
You know, you can't
My
always
son
get
used
it your
to say
way.
that to me. I'm not talking to you.
This is
Anyway,
pretty dramatic. This is much more dramatic than the first case, I just want to say.
It is. I don't like New York. San Francisco, where are you? What do you need? Anyway, I totally agree with David. So, I mean, I think single tablet regimens are terrific in the right patient, but not one size fits all, and that we should be individualizing therapy. So nice that we have choices.
David, did you agree with your argument, even though you reluctantly
I
took
totally
it?
disagree with myself. Yeah, I took this one on as purposely because I thought it was the one that would be hardest to defend. I thought that'd be fun. But the more I thought about it, the more I kind of convinced myself it's true, especially as we think about these other regimens. So yeah, I think what I said is right.
Yeah, I think, all things being equal, I think patients will always choose single
Right,
tablet
sure.
regimen,
Right.
but I'm not convinced that it changes outcomes.
Right.
And I do think there are a lot of subtleties here that might influence whether a single tablet's right for any given individual. So, okay, great. So the outcome question, you're counseling a new HIV-infected patient on his options, 34 years old, RNA of 172,000, CD4 405. He's positive for HLA-B5701. I don't know where we found all these HLA-B5701 positive patients. And he has a creatinine clearance of 60 mils per minute. His HIV resistance testing shows the K103N and K103S mutations are present. If you're following the current guidelines, which would you choose for this patient? The elvitegravir-Cobi single tablet, dolutegravir single tablet, efavirenz single tablet, rilpivirine single tablet, or you would say he's not a candidate for a single tablet regimen or you're not sure. And again, the key information is listed at the bottom. Go ahead and vote. Okay, so 40, I have a bad angle, so it's
43.
Yeah.
43% said he's not a candidate, 26% picked efavirenz. Oh, no, elvitegravir-Cobi.
elvitegravir.
Okay.
Great.
Yeah, so, I mean, the issue here, the subtle issue here that I think people might have missed is that the current guidelines and the package insert for elvitegravir-cobicistat to not for FTC is only for people with creatinine clearances of over 60 mils per minute, or 70 mils per minute, and this person was 60. And that may all change.
Yeah.
Now we have a lot of data looking at these drugs at people with over 50 mils per minute, and then TAF might change things further, but at least for now, that would have made this less than optimal choice. And unfortunately, he can't take abacavir. He's resistant to efavirenz, and then rilpivirine's not for FTC. He has the high viral load, so he's not a great candidate for it. So I think 5 is probably the best answer.
Eric, just really quick, I know we're short on time, but would you think 1 would also be somewhat, are you worried about the resistance at all, that there might be some hidden nucleoside resistance that's just not detected?
So I used to spend a lot of time worrying about that, but I think we have quite a bit of data, including from the pivotal trials for elbitigrate or cobicistat, which allowed people in that had baseline NNRTI resistance.
What about NRTI resistance that might be harbored there as well?
Well,
but not-
so the assumption is that those, if that exists, it
Yeah.
would have been present in those people. And at least in the studies,
I
those
see.
people did well.
Right.
So that's always been the concern, is there more
Got it.
hiding, and the fact that we allowed them in and didn't appear to influence their outcome. I do think that scenario is a little different when you're talking about treating people when you don't have resistance data available.
Right.
Because then you can't exclude
Right.
certain types of resistance. Okay, so this brings us to our last case, or last question, and that's boosted PIs are no longer appropriate in first-line therapy for most patients. And David is going to argue for this, and I will argue against. So first, let's vote, and we'll hold the results for this if we can. Is that possible? Not possible. Okay.
Everyone cover your eyes.
Okay. But it's no problem. Okay, that would be great. So boosted, and I won't comment. Boosted PIs are no longer appropriate in first-line therapy for most patients. You agree, disagree, or you are undecided?
Oh, good.
Okay, whoa, that was really quick. Well done.
Very good.
Well done. So,
Take it away. Yeah, so I think that's the key question here is are they appropriate for most patients or not? And I'll indicate that it's not appropriate for most, underline most patients who are starting therapy. Again, I think just taking a step back and looking at this, there was a time when this was a no-brainer, that boosted PIs were what we needed. They were potent. They really had special qualities as far as preventing resistance. And even though they had baggage, and we know about the baggage, and I'll highlight that, their value was their potency and sort of their resilience and durability. The world has changed, though. And I think that we have to really look at boosted PIs as being anachronistic and something we used way back when, but that we've moved on to. And I would say, I would challenge anyone in the room to come up with a case where you really feel a person needs a boosted PI nowadays. And the reason I say that is because we have really good other therapies, including now regimens where resistance is highly unlikely. Okay, so we know that the baggage there, was there, but there are qualities and benefits of boosted PIs that outweighed or countered some of that. And I'd say now that we have other regimens that are not boosted PIs that have those same qualities, but without the baggage, tips the scales wildly away from the boosted PIs. So why do I say that? Well, we know that the boosted PIs as a class have a number of different issues. First of all, they're multi-pill, and we all know that multi-pill is bad. Right? Second of all, there's the general toxicities, and we just have literally been swallowing that for years because we had to, but we don't have to anymore. So we can get under the, out from under the yoke of boosted PIs and their lipid problems, their GI intolerances, and the drug-drug interactions. I mean, why are we putting up with this when we have really good alternatives? So you'll say it's because I have my patient who comes in, I'm not sure if they're going to take their medication, they may develop resistance due to non-adherence. That's why God invented dolutegravir, all right? So it's 2 years now that we've got dolutegravir data, and Kate's going to show you slides of boosted PI studies where there's 0 or 1 resistant mutations, and the same thing is true for dolutegravir. If it's going to happen, if
I think your time is up.
I'm done. I'll show you one slide. So that's just what it takes. Next slide is really the key slide. When you look at different arms of different studies done over the last decade or so, and you look at how do PIs perform, how do integrase inhibitors perform, NNRTI, the green is PI. In getting people, we've tolerated this. They haven't done as well as we've even thought. And integrase inhibitors now are doing so much better. So they're more potent, they're better tolerated, and now we see indemnification against resistance. Next slide. Even within ACTG study comparing raltegravir, a twice-a-day regimen, compared to once-a-day boosted PIs, raltegravir beat the pants off of both of the boosted PIs. It's a composite of tolerability and virologic outcomes. That's what we want. That's what our patients want. It's not good enough to say, oh, this will get you undetectable, but it'll make you sick. We care about both things. Next slide. Bone, we saw benefits of bone as well with the integrase versus the boosted PIs. Sort of a thing that we didn't really pay attention to. It looks like boosted PIs cause more trouble with bone. Next slide. Nausea, diarrhea, enough said. Next slide. Okay.
Especially
Lipids,
during lunch.
done. Next slide. Associating with MI, we think about abacavir. The first DAD study showed, the first time the DAD came out and said there's something going on with ART and myocardial infarction, the culprit was PIs. Again, we've tolerated this when we had to, now we don't have to anymore. Next slide. We also know increasingly not only there are bone effects of the boosted PIs, but we're also seeing CKD, so kidney effects. We know that atazanavir crystallizes in the urine and in other places and causes probably some low-level inflammation in the kidney. Even when you correct for tenofovir and censor tenofovir, there's an effect of boosted PIs, and I think it's going to become a class effect. This you'll just memorize, right? This is what we've got to deal with. This is impossible. Our patients are getting older. Comorbidities are more and more of a problem. We don't have to deal with this any longer. Next slide.
Okay,
Now I'll
well,
turn it over to Kate.
well, Kate actually is not going to tell you
Now
anything.
turn it over to you.
You're going to turn it
You may
over to
want
me,
Kate.
and he said he would challenge anyone in the room.
Yeah, tell me.
That would be me.
Yeah.
So, you know, it's kind of a ludicrous argument since we've been using boosted PIs for so many years, and they really, really defined the face of the disease and gave us an option that almost was foolproof, and that you couldn't go wrong with the most important irreversible side effect of therapy, and that is the emergence of resistance. We have data now with many different PIs showing very potent. Virologic efficacy has been virtually equivalent in every single study. And again, I focus on virologic efficacy because I think that's most important. The side effects are a little different. People leave studies for lots of different reasons. Low rates of transmitted PI resistance. In fact, if you look at the data slide of transmitted resistance, none of the resistance listed under PIs is clinically relevant. Virtually all of those people can be successfully treated with the boosted PI. It's rare at virologic failure, and rare is an understatement. There are few things less rare than the emergence of PI resistance on a PI-based regimen. There's also not just low risk of PI resistance, but the nucleoside risk of resistance with nucleosides is also low. When somebody fails a boosted PI, they have virtually all options left available to them. Multiple boosted options, including fixed-dose boosting combinations now with cobicistat, so we're able to even reduce what was a 3-pill regimen to a 2-pill regimen, and as was stated earlier, they're in development as a single tablet regimen with the boosted PI that will include TAF, FTC, darunavir, and cobicistat. So this is just some of the efficacy data with the preferred option, darunavir, and recently referred, although now recommended, an alternative option, atazanavir, at week 48 and 96 from these key studies, showing very high rates of virologic efficacy. This is that resistance data. PI resistance is rare, and like I say, even the 4% or so that have transmitted resistance, it's not, for the most part, not phenotypically resistant to boosted PIs. So boosted PIs can be used in virtually all patients with transmitted resistance. Here's the data on several of the key studies looking at major PI mutations emerging. You can look at the ends here and do the math. It ends up with thousands of patients treated with boosted PIs. And then you look to the far right column and you see 2 with emergence of resistance, neither of which had significant phenotypic resistance to PIs. It is just an absolute. And for David to suggest that God invented dolutegravir so that people wouldn't have to worry about developing resistance. In the face of this data, it's clear PIs were what were invented for that purpose. They have been and continue to be for that purpose. You just don't ever have to worry about something going wrong with regards to resistance. The DHHS guidelines specifically state there are key situations where a boosted PI is probably going to be preferred. There are many situations where it's a recommended option. Darunavir, ritonavir continues to be, but those people with particularly high concerns about adherence, whether they'll come back to clinic, the people that you need to rush on therapy before resistance data is available, which is becoming increasingly common for those who take care of people admitted to the hospital with advanced disease, where we're often trying to get them on therapy earlier. PIs would be a preferred option in that case. Viral failure on a boosted PI with NRTI first-line regimens. There was a systematic review looking at people who failed boosted PIs, looked at what they were switched to. Some switched to new drugs, some switched the nukes, some stayed on their current regimen with enhanced adherence. It doesn't matter. It's almost always just simply an adherence issue. So let's go ahead and vote. Boosted PIs are no longer appropriate in first-line therapy for most patients. Do you agree, disagree, or undecided? Wow. This was futile. I guess we don't know. It could be across individuals there were change, but across the population, it doesn't look like we had much influence. So about 2/3 disagreed at the get-go.
Right.
And still disagree.
Yeah.
Okay, fair enough.
Good.
David?
Yeah, you know, I think that it is increasingly difficult to think of who would be a good candidate for a boosted PI nowadays. I do think that if the dolutegravir story continues to hold up, that's going to make it really hard to use a boosted PI. I was excited about the single tablet boosted PI regimen that's in development, but it's not going to be until at least 2018, and by that time I think we're going to be so much more comfortable with using dolutegravir and others that I don't think that's going to really play as much of a role anymore.
Yeah. I think it really, in my mind, it really comes down to the dolutegravir story. PIs are clearly unique for all the reasons that we said. I think we all agree. For those patients that you're worried about adherence, whether they'll come back for their visits, there's nothing safer to give them than a booster. You just can't go wrong as far as a resistance perspective. Now, we'll see if dolutegravir holds up. I mean, so far the data is incredibly compelling for treatment-naive patients, and even in treatment-experienced resistance is rare, and in even a post-hoc analysis looking at people who are treated with partial nuke activity and dolutegravir, they saw high virologic response rates. If that all plays out over the next year or two, then clearly we will have an alternative to a boosted PI for these specific types of patients. I think it's a little too early to be sure that that's going to be the case. So I still use boosted PIs. I take care of an inner-city population of high-risk patients. I still use boosted PIs in the people that I'm really worried about. And when we talk about adherence nowadays, we're not talking about less than 95%. We're talking about the people I don't know if they're going to show up for their next appointment. Those are the kinds of people that I still use boosted PIs, and I tell them, yeah, right now it's 2 or 3 pills, but once you're suppressed and you're doing well, we can always switch you to a single tablet regimen. Kate?
Ditto.
Ditto. Okay. So the outcome question, 49-year-old man presents with an acute opportunistic infection, diagnosed with HIV, RNA is 120,000, CD4 150, he agrees to start therapy immediately, and you have to select a regimen before resistance data is available. He's a flight attendant and is concerned about his ability to maintain a regular schedule with his meds. So which of the following would you choose in this particular patient? Efavirenz, tenofovir FTC, elvitegravir, cobicistat, darunavir, ritonavir, tenofovir FTC, raltegravir, tenofovir FTC, or you're not sure? Go ahead and vote. And if people have questions, I don't know if cards have been circulated, nor do I know how much time we're going to have. So, okay, so
They like their boosted PIs.
60% went with the boosted PI. A quarter went with elvitegravir cobicistat. Interesting. And we did not have dolutegravir as an option.
Right.
So that's interesting. David, what do you think?
Yeah, at first I was like, were they paying attention? And then now but without the other alternative there of dolutegravir, I think this makes sense. I mean, he has a lowish CD4 cell count, so people get concerned about that, and he's got crazy schedule, so I could see this. And I think number 2 is probably what I would have chosen, but I could see why people might have gone with the junior. It's 3 pills. He's a flight attendant. It means he has insurance, which means he has co-pays. So when he says to you, I've got to pay $30 per co-pay, doc, you got anything else? It'd be interesting to see what people say.
Yeah, I think those are obviously probably the 2 best choices for this particular patient. And you could argue that integrase resistance transmitted resistance appears to be rare. There's literally case reports, but we haven't been systematically looking for it. And in all likelihood, it is going to become more common in the future as we use them more frequently. But but at least so far it appears to be
Yeah.
rare, so rare that the guidelines don't recommend that we even look for it. So you could make the case that it's not pending in this case because we're not looking for it. So we're never going to know if this person has integrase resistance, even if we waited. I guess the thing that would concern me a little bit is the transmitted nucleoside resistance. And the difference between this patient and the patient we talked about earlier, we worried could there be transmitted nuke resistance, but there was none detected. In this patient, we don't know yet. And while nuke resistance is less common than non-nuke, if this person had transmitted nuke resistance, I think we would all agree this would be an inappropriate regimen. So that would be the one risk of going with that versus the boosted PO.
Pretty low risk, but I understand what you're
Yeah.
saying, but low risk.
I don't know. I would just say low, not
Say
low.
Low risk.
Okay. So if we don't have any questions, I know we're pretty late in the hour. I want to thank my panelists for the arguments and debates. Thank all of you for your active participation. I think this was terrific. I really appreciate it, and enjoy the rest of the meeting.